I'm intending to say just a few words about what's happened in terms of physical health care in the high secure hospitals from a commissioner's perspective. But first, just some general remarks. And I guess my health warning about my remarks are that they are the world according to Paul Meechan. They are very much a personal view, not a statement of commissioner policy. But what does good commissioning look like? I guess my view would be that if you can see it, then it isn't good commissioning. That's not to say that commissioning is not important. On the contrary, I think it is. However, if commissioning is characterised by a habit of tinkering, of over-involvement, a bit like a kind of over-enthusiastic mechanic, then it strikes me that it's an immature model. And maybe sometimes that's just a reflection of an immature system. But in any case, I think we do have to try to move beyond that and keep our eye on a wider horizon. Good commissioning, it seems to me, is catalytic. In other words, it's an agent that supports something happening but isn't part of the thing happening. You shouldn't see it in the middle, you shouldn't see it at the end. It's also primarily achieved, I think, through collaboration. I think it's primarily achieved through strengths of relationships. Commissioning, as I'm sure all of you will be aware, has been very much at the front and centre in the last year or so in terms of the Health and Social Care Bill. I don't intend to dwell on that, but I think it is important to outline some of the principles that drove the agenda in terms of high secure commissioning of physical health care. There were some clear, agreed principles between the three high secure providers and the commissioners. It was around achieving at least community equivalence of primary health care provision in the high secure hospitals. It was about having a whole population focus. It was also about targeting some very specific issues, principally some of the clear challenges we have in terms of long-term conditions. And finally, it was about delivering an integrated pathway. I think we've made some headway, and I'd like to talk about that very briefly. I think there's a long way to go. So, the abridged history. I guess it was about 3 years or so ago, perhaps a bit longer. It certainly predates my time in this post, and certainly is a great credit to the then National High Secure Commissioning team. There was a strategic focus placed on improving physical health care in the high secure hospitals. Indeed, there's a very clear commitment made to that objective in the High Secure Strategic Commissioning Plan. The High Secure contract, which came online 2010-11, included a service specification common to all three hospitals. And interestingly, we're moving now to national specifications for for specialised services. But I guess we were a bit ahead of the game in that regard in high security. The service specification had a very clear and detailed description of the expectation of delivering a primary healthcare service within each of the high secure hospitals. The intention was that it would be integral to what high secure hospitals do. In our attempt to help deliver that, we used Sequin. I guess we used it essentially to shine a light on primary health care, to give it some focus in the hospitals. Clearly, it also targeted resource. We put money against improving, achieving some improvements. There was a view at the time, and I think to some extent is still prevalent, that primary healthcare was business as usual, and sequin wasn't an appropriate use of resources. I certainly don't agree with that. I'm glad to say I don't think my colleagues agree with that either. We all know the intelligence about mental health service users accessing physical health care. We understand the health inequalities. Steve has talked about it this morning. Ironically, perhaps this is even more challenging in secure mental health services. The sequin targets, I think, were initially a very blunt instrument, but we have got better, largely by trying to listen more to the primary healthcare clinical teams. We have had a better focus on population health. I think using QOF standards as a benchmark for measuring improvement, we returned to that principle of equivalence with community services. We have achieved better data collection, although clearly, as Julia points out, there are still some gaps. But there has been improvement across all three hospitals. There has been a very clear focus on long-term conditions and consistent approaches to tackling them. These aren't easy issues with the patient group that we are dealing with. They're not easy issues in the environments in which you're working. But I think we have made some headway. Clearly, there is still a way to go. I think principally, for me, the big challenge is achieving integrated delivery. And I think one of the risks is that we have kind of parallel systems in the hospitals. So we have mental health care, we have security, and we have primary health care. And they all do, a high standard of work, but actually they don't quite meet. It's a parody, I know, but I think that's the risk that we have to keep always at the front of our mind. And in terms of integrating delivery, I think there are some key issues for me. There is something about embedding physical health care in the CPA process consistently. It does happen, but it needs to, I think, have a higher reference point. Embedding physical health care outcomes in recovery planning. Recovery planning in the high secure hospitals is relatively young. It's got a long way to go. We have to ensure that physical health care doesn't lose sight of that. We've heard some discussion about integrated electronic prescribing systems that include primary health care and some of the advantages that might give. And we would, I think, be supportive of using some sequin incentives to help support that going forward. Rampton Hospital has, in the last year or so, done a lot of work piloting telemedicine, again, as a result of sequin projects. We need to learn from that experience, understand what the benefits in terms of quality and the cost benefits might be. We need to take, I guess, a whole pathway approach. There is something really important about continuity of physical healthcare planning outside of high security. It's really no good, I guess, if we do something really great in high secure service and people move to medium secure and through the pathway and it kind of falls apart. So there's something about ensuring that we work beyond our own boundaries and have a whole pathway approach. Clearly, we need more concentration on public health, more focus on long-term conditions. Going forward, in a radically changing commissioning landscape, I think it clearly is important that we don't lose focus. The key principles are the same: equivalency, integrated delivery. However, I think there are some real opportunities in the new commissioning world. secure services will have a single commissioner. The commissioning board will be influential. It will have the power to make real difference. Hopefully, we can keep that difference focused on agreed high-level outcomes. We're moving towards national specifications, which will include all secure services. The specifications will be online shortly for consultation. Please do look at them. Please do look at them in light of the issues about providing physical health care. And if you don't think it's robust enough, please do comment. The NHS Outcomes Framework and Emerging Commissioning Outcomes Framework sets the agenda for improving outcomes for all users of the NHS. Secure mental health cannot be an exception. The challenge, however, is how do we map it into the secure setting in a way that makes sense. I think there's a risk about just rushing ahead and not just taking a moment maybe to step back and see how do we do what absolutely has to be done in a setting that is unique. Finally, I really do welcome this conference. I welcome you today. I think I was saying earlier, I think we've kind of tapped on a nerve somewhere, the interest about today's conference. I really hope that today the discussion will help to keep the light shining on delivering physical healthcare outcomes for those in secure mental health settings. I'd like to thank you for your participation, and I look forward to seeing you during the day. Thank you.